Powerhouse right coronary artery with anomalous left anterior descending and absent left circumflex. Background. Coronary artery anomalies are found in less than 1% of the population. An anomalous origin of the left anterior descending artery from the right coronary artery or right sinus of Valsalva is found in only 0.03% of the population. Additionally, the absence of a left circumflex coronary artery only occurs in between 0.003% to 0.067% of the population. Anomalies of coronary arteries are known to be benign and asymptomatic. However, 20% of cases have significant clinical symptoms. For instance, dyspnea, palpitations, angina pectoris, dizziness, and syncope. Symptomatic patients have three treatment options: medical observation, coronary angioplasty with stent deployment, and surgical repair. We report a rare case in which our patient was incidentally found to have an absent left circumflex, an anomalous left anterior descending origin, and a dominant right coronary artery supplying the majority of the patient's myocardium. Case presentation. A 58-year-old Caucasian female presented with worsening chest pain and dyspnea on exertion for approximately 1 year. Stress electrocardiography 2 months prior to admission revealed sinus rhythm with no perfusion defects. Her echocardiogram revealed a left ventricular ejection fraction of 50%. Coronary angiogram of the right sinus of Valsalva revealed an anomalous left anterior descending artery and a right coronary artery with an unusually large caliber and distribution. The distribution of the right coronary artery was so vast it involved the left circumflex territory. The coronary angiogram also revealed an absent left circumflex when contrast was injected into the left coronary cusp. To confirm the coronary angiogram findings, a computer tomography angiography of the coronaries revealed the left anterior descending artery originating from the right sinus of Valsalva, inferior medial to the right coronary artery. Additionally, the left circumflex was absent, and a large right coronary with posterior lateral branch supplied the left circumflex territory. Discussion. Coronary artery anomalies affect around 1% of the general population, ranging from 0.3% to 5.6% in studies on patients undergoing coronary angiography and approximately 1% in routine autopsies. The clinical symptoms of patients with coronary artery anomalies vary according to which group the anomaly falls into. Anomalous coronary arteries can cause sudden cardiac death, mostly in young patients, dyspnea, palpitations, angina pectoris, dizziness, and syncope. An absent left circumflex coronary artery should be considered in patients with chest pain and differentiated from atherosclerotic coronary artery disease for better management and prognosis. The congenital absence of the left circumflex results from the failure of the left circumflex development in the left arterioventricular groove. Absent left circumflex can be benign or it can cause angina-like symptoms, particularly on exertion. The most accepted hypothesis proposes that this phenomenon is due to the coronary steal principle. Our patient presented with chronic progressive angina and dyspnea on exertion. Management is focused on decreasing symptoms with medical therapy, coronary angioplasty with stent deployment, and surgery. Conclusion. Coronary artery anomalies can be found incidentally when working up unspecified causes of chronic progressive chest pain and dyspnea. Understanding various morphologies of coronary artery anomalies and its physiological consequences is critical in managing such patients. Acute recognition and intervention can avoid catastrophic consequences, especially in patients with one vessel supplying the majority of the heart.